And as you can tell, I'm not Dr. Roman. He's out of town, and he asked me to start things off in his absence. It's a little bit late notice, so I unfortunately don't have any of his fun tidbits to share with you. So we'll go straight into our introducer of our speaker, and Dr. Bill C., who is the director of our bone marrow program here, is going to introduce our speaker.
Thank you, Barbara. Since Dr. Roman is not here, I just try to, for the formality, fill in some kind of a history. So related to our university, also the speaker tonight, this morning. So a group of a Russian romantic nationalist movement in music was called Mighty Handful. One of its members, who is not only a composer, but also a physician and chemist, Alexander Borodin, was born today in 1833. Another French sculptor, Auguste Rodin, who created a famous thinker sculpture that one of his real one is in our campus. He's also born today in 1940. The other one is a Beatles member, Paul McCartney, released We All Stand Together, use the animated film. What's the name of the film? Rupert and Frog Songs. Was released today in 1984. So it is my great pleasure to introduce today's grand round speaker, Dr. Maxwell Krem. We recruited Dr. Maxwell Krem as a co-leader in the lymphoid malignancy program from University of Washington and Fred Hutchinson Cancer Research Center in Seattle this May. He quickly demonstrated that he is one of the star recruitment at the BMT division. Dr. Krem obtained his MD and Ph.D. from WashU at St. Louis and completed his internal medicine residency training at Barnes Jewish Hospital. Then went on to receive medical oncology BMT fellowship training at the Fred Hutchinson Cancer Research Center, University of Washington, Seattle. Upon graduating from his fellowship training, he stayed on as a junior faculty member at the Hutch, University of Washington in Seattle, VA. He is a very productive clinician, scientist, and a passionate physician. He also is a very sophisticated classical music lover and worked as a radio host in a classical radio station in St. Louis when he was a medical student there. He composed his own Symphony C when he was a medical student at WashU. I believe this is one of the reasons Dr. Miller helped me to recruit him come to this campus. Now let's welcome Dr. Maxwell Krem to give us a medicine grand round today, and the title of his talk is Novel Targeted Therapy for Low-Grade Lymphoid Malignancy that make his fame as one of the national key opinion leader at the American Society of Clinical Oncology this year.
Well, thank you for the introduction. I think I probably should have given a talk on music therapy instead, though. So we'll be discussing some of the new classes of agents for treating low-grade lymphomas with an emphasis on older adults. And my disclosure is that I'm the PI for a clinical trial that's industry-sponsored at the University of Louisville, which we'll actually discuss in our future directions section. So in today's talk, we are going to focus on the biology of low-grade lymphoid malignancies. We'll discuss the mechanisms of action of many of the new agents that are being utilized. And we'll spend most of the talk on recent clinical trial data and how that applies to our treatment of these diseases, and especially how older patients tolerate treatments, because they're the majority of individuals who have these diseases. So lymphoma is a malignancy of the lymphoid system of lymphocytes, and we group it based on morphology into Hodgkin lymphoma and non-Hodgkin lymphoma. Hodgkin lymphoma is a small subset where there are large multinucleated cells called Reed-Sternberg cells, and the vast majority of lymphoma is not that. It's non-Hodgkin lymphoma. And we tend to classify NHL into more aggressive and less aggressive phenotypes, and we treat the less aggressive histologies very differently. In fact, we're going to focus an entire talk on them, and we call them indolent NHL, and that's the WHO terminology. So we'll go through the pathobiology, and then we'll focus on clinical trial data for 4 major classes of drugs. Drugs that target CD20, like rituximab, drugs that target the phosphatidyl inositol 3 kinase signaling pathway, immunomodulators, or IMiDs, and then we'll go on to proteasome inhibitors. We'll briefly mention drugs in some new classes that are being studied in early phase trials, and then we'll close the talk. As I mentioned, we group non-Hodgkin lymphoma into indolent and aggressive histologies. And the indolent histologies include chronic lymphocytic leukemia, also known as small lymphocytic lymphoma, when there is not substantial blood circulation, lymphoplasmacytic lymphoma, which is more commonly called Waldenstrom's macroglobulinemia, and most cases of LPL meet the criteria for Waldenstrom's. Marginal zone lymphoma, and finally follicular lymphoma. Follicular and CLL are the most common subtypes of indolent NHL, and what all of the subtypes have in common is that they affect older populations more. The median ages, as you can see, range from the 60s to the 70s for all histologies. In addition to the later age of presentation, these diseases tend to have courses that run for decades. So this poses the clinician with the problem, how do you manage this disease in patients who range from their 70s to their 80s and even their 90s? And that's the challenge we're going to face in the upcoming decades. For example, in an observational study of about 1,500 CLL patients, older patients had more comorbidities. They also had less performance status, which is a general measure of a patient's physiologic well-being. And their renal function was not as good. So your older patients, which are the majority of your patients with indolent NHL, have a decreased performance status, more comorbidities, and actually the observational study also showed they tend to have more advanced disease at treatment initiation. So all of these are poor prognostic factors. And Tanya Wilds and her co-authors have published on the fact that older patients with these diseases also have decreased tolerability of treatment, and they experience serious adverse events at much higher rates than younger patients. So how do we get into this situation? Well, we can blame our biology. And one biologic factor is the telomere. Telomeres are DNA sequences that are found as the end caps of chromosomes, and they help protect against chromosomal instability. And specifically what they protect against is something called a breakage-bridge fusion cycle, described here, which can give rise to translocations, which of course we don't consider to be good. As our telomeres get shorter, which happens as we age and as cells become senescent, there is more risk of chromosomal breakage events. And in part, this happens because we have decreased expression of telomerase or reduced function of telomerase. And this is seen in CLL. And in fact, there's a very good correlation of outcome with biology, that in CLL, the shorter your telomeres are, the worse the prognosis is. So here's one good correlation of a biological phenomenon with a clinical outcome in older patients. Another possible explanation for increased incidence of these diseases in the older population is the phenomenon of the B cell receptor. So the B cell receptor is an immunoglobulin superfamily type protein, and you can recognize the immunoglobulin-like structure, and it sits in the cell membrane and is associated with signal transduction domains. So it plays a key role in recognizing antigens. When the B cell encounters an antigen, the receptor binds it and triggers signaling. And it is this signaling that helps B cells proliferate and develop mature responses to antigens they encounter. As we get older, our diversity of B cell receptors decreases. In part, this is likely because we select the B cells that are better at recognizing antigens. So this is good for our immune system in one way. We want the B cells that can recognize antigens and respond to them the best. But the other edge of the sword is that we are selecting for stronger signaling B cells, and we potentially can select for tonic signaling in a growth receptor, which, as we know in other examples of oncology, such as the EGFR in lung cancer, that's not good. Another factor is the presence of chromosomal translocations. Translocations are double-strand breaks in chromosomes that lead to the pairing of one chromosomal segment with a section from another chromosome. And why they can be deleterious is that, at least in lymphocytes, we can take a promoter region, which is associated with heavy activity, such as immunoglobulin promoters in B cells, because that's what they are. They're immunoglobulin factories, and so they have very strong promoters for the Ig genes. And the translocation can pair an immunoglobulin promoter with an oncogene. And pairing an immunoglobulin promoter with an oncogene is a recipe for turning on a cancer-promoting gene strongly. One example of this is immunoglobulin heavy chain on chromosome 14 with BCL2 on chromosome 18, which is considered very characteristic of follicular lymphoma. When we are born, we don't circulate any copies of this translocation. But as we age, for example, when we're finishing our fellowship and becoming faculty members, we start to circulate this translocation, and by the time you're a division chief or a senior faculty member, you're at your maximum circulation of 14-18 translocation out of your peripheral blood mononuclear cells. And the peak circulation decreases after retirement, but doesn't completely go away. So this peak in age actually corresponds very nicely to the peak incidence of follicular lymphoma and helps explain in part why this is more a disease of older patients. Although I should mention that the translocation in and of itself is not pathogenic. Other factors are required, but it certainly does not appear to be helpful to have more of these translocations running around. Another couple factors which are primarily seen as correlates from animal studies, the marginal zone pool, which is the area in the spleen between the red pulp and the white pulp, seen here, increases with age, at least in mice, and it might do so in humans. And that is where marginal zone lymphomas are thought to come from. And as mice age, their ability to perform class switch recombination, which is an essential function to making the variety of antibodies you need to fight infection, that function becomes more deficient. And if you have problems with cutting and pasting your DNA, that can lead to translocations and thus chromosomal instability. So now we'll shift to the meat of the talk, which are the novel agents and the mechanisms of action. And we'll start with CD20. So rituximab is probably the most famous anti-CD20 agent, and we'll spend some time in this category. So CD20 is a marker that is expressed on the majority of B cells, and it's seen in almost all B cells with the exception of plasma cells, which are the most terminally differentiated, and pre-pro B cells, which are the most immature. So that's why rituximab isn't used to treat ALL, which comes from the most immature B cells, or multiple myeloma, which comes from the most differentiated ones. But otherwise, CD20 is on the majority of malignant and non-malignant B lymphocytes. And we can kill these lymphocytes with an antibody directed against the molecule. And the way rituximab and similar antibodies function is that they bind to the B cell, and this attracts immune effector cells, such as NK cells and T cells, to perform antibody-dependent cell-mediated cytotoxicity, or ADCC. Binding of the antibody to the cell can generate activation of the complement system and insertion of membrane attack complexes into the cell membrane, which leads to cell death. And finally, the binding of antibody itself to the cell can trigger internal apoptotic pathways in cells. So those are the major mechanisms by which rituximab and other CD20 antibodies function. And just to give you some historical perspective, rituximab was developed in the 1990s and approved in the late 90s, and ofatumumab, which is a humanized anti-CD20 antibody, was developed in the 2000s and first approved in the late 2000s, and obinutuzumab, which was a Genentech Roche agent, GA101, which is a further humanized monoclonal antibody against CD20, was just FDA approved for CLL last year. We group these antibodies into two major subsets. The first group, the original antibodies such as rituximab and ofatumumab, are called type 1 antibodies, and they're called that because they group the CD20 molecules on the cell membrane together into rafts, and that's part of how they function, by herding the CD20 molecules together. However, the newest antibody, obinutuzumab, actually doesn't do that. And the result in the slightly different mechanisms of action is that the first group of antibodies functions more through ADCC and complement, and obinutuzumab has a more prevalent role for apoptosis in its functioning. So getting to the clinical aspects, ofatumumab was approved for CLL in the relapse setting and the first-line setting recently, and some of this data was the Complement-1 study, which we will discuss in minor detail, and we'll focus more on obinutuzumab, which is the newest agent, which has been approved for first-line CLL, and it was approved based upon the phase 3 CLL-11 study, which was primarily conducted in Germany, which was a 3-arm study of obinutuzumab and the oral alkylator chlorambucil versus rituximab and chlorambucil versus chlorambucil alone. And the CLL-11 study raises some interesting ideas about cost effectiveness, and so we're going to spend a little bit of time on that. So the key results of the CLL-11 trial, which combined a low dose of the oral alkylator chlorambucil with either rituximab or obinutuzumab, showed that the obinutuzumab chlorambucil arm improved response rate, minimal residual disease, and progression-free survival the most of the 3 arms studied. And it did so against rituximab and chlorambucil. And as we can see, most of the improvement in response rate was in complete responses, and minimal residual disease improved somewhat, and the progression-free survival curve had an 11-month difference. Some of this is not in perfect focus, but that was about 26 months versus 15. So that seemed very promising. However, when you look at the overall survival endpoint, obinutuzumab versus rituximab was not significant, but obinutuzumab added to chlorambucil significantly improved overall survival. So I should mention that as the comparator arm, chlorambucil is a relatively weak comparator arm. Chlorambucil is typically a regimen that is reserved for the oldest, most comorbid patients with CLL who cannot tolerate even rituximab as a single agent or any form of combination therapy. That's typically how chlorambucil has been used. So as a comparator arm for this study, it is relatively non-potent. So looking at an overview of the ofatumumab and obinutuzumab data, and I'll just call them OFA and obina, and this is a complete word salad. I don't know who really named these antibodies. Ofatumumab and chlorambucil versus chlorambucil alone, we see that in this study population, so fortunately they did choose a study population that's older, so this is a little bit more applicable to real-world CLL treatment. Ofatumumab improved response rate and progression-free survival. Toxicity did not significantly increase. There was some risk of infusion reaction of grade 3 or higher, which are serious infusion reactions, not necessarily requiring hospitalization, but certainly requiring stoppage in therapy or increasing the pre-medications or giving fluids. These are the people who get close to being hospitalized, but not to the extent of anaphylaxis. Grade 4 would possibly be anaphylactic infusion reaction. And death rate was similar. Infection rates in all CLL studies will be high because CLL is a disease which has a high predisposition to infection. And in the obinutuzumab CLL-11 study, once again an older patient population, we saw that the obinutuzumab arm had the highest efficacy in terms of response rate and progression-free survival, but it came at a cost. The toxicity was the highest, and a lot of that toxicity was from infusion reactions. Now, these are humanized antibodies, supposedly. Rituximab has that little XI in the name, which means it's a chimeric antibody. It has mouse sequence. One would expect it to be the most activating of the immune system, but in fact, it's the least immunoactivating antibody. And it appears that obinutuzumab has the highest rate of infusion reactions. And death rates were similar across the studies. So these new drugs have efficacy. Some would argue better than rituximab in combination with alkylator chemotherapy. I might argue that we don't really know the answer to that question because the alkylator used in the studies was relatively weak. And in the CLL-11 trial, they used potentially the lowest possible dose of chlorambucil that you could get away with. But a Canadian study based upon the complement 1 trial concluded that the cost for a quality adjusted life year was about $68,000. Now that's Canadian dollars, and so their dollar has gone down, so it might be more cost effective these days. And obinutuzumab, in a company-sponsored study, I should mention, was shown to improve the number of quality-adjusted life years by a small amount versus rituximab. And they thought it was 89% chance that it was cost-effective at the $100,000 threshold. The $100,000 threshold is relatively significant because right now that approximates with the cost of dialysis for a year. So that's a benchmark that's often used for assessing cost effectiveness to gain a QALY, which is the equivalent of someone living a year longer without having any major negative effect on their quality of life. The English conducted their own study of obinutuzumab's cost effectiveness, and they concluded that the cost to gain a QALY versus rituximab was only $45,000, and this is in US dollars, not pounds. But it was not quite as cost effective against bendamustine rituximab, which is a stronger alkylator, the bendamustine. And they decided not to fund it based upon these numbers. They decided that $45,000 for a quality adjusted life year did not justify the expense and the additional infusion reactions and adverse events in the older patients. And Genentech and Roche came back to them and renegotiated a better price, and they changed their decision. So what happens in the United States? We have slightly different medical economics. And I should mention that since the publication and approval of the obinutuzumab chlorambucil trial, obinutuzumab and chlorambucil has become a very popular regimen for the first-line treatment of CLL. And I can't say that it supplanted any other chlorambucil regimen. Very few people were using chlorambucil back in the late 2000s up to 2010. And rituximab chlorambucil, which was a regimen that existed, was not used that much, although it is a reasonable regimen. So why did obinutuzumab chlorambucil become so popular? Well, I think some of that's the health economics and how these drugs are priced and reimbursed. So now this, of course, different health systems have different economics, and HMOs this might not be applicable to them. But if you are buying and billing for the drug, Medicare Part B will reimburse you the average selling price plus a 4.3% margin. It used to be 6%, but after sequestration, that number was reduced, and it will stay at 4.3%, presumably until 2024. The infusing practice, though, makes approximately a 4.3% margin on chemo. Now, that may not be a profit because they have other expenses to deal with, but it turns out that obinutuzumab is more expensive than rituximab based on how it's priced. And so I made an assumption that the patient would have a body surface area of 1.7 meters squared. And I tried to pick a body surface area that's very typical for patients we see, so not to try to bias it one way or the other. Obinutuzumab's pricing is fixed because the dosing is fixed. It doesn't change. So the obinutuzumab is much more expensive in the first cycle and a little bit less expensive in subsequent cycles based upon the different dosings of the drugs in CLL. But it turns out the total wholesale price is $10,000 more for obinutuzumab than for rituximab for a 6-cycle or 6-month course. And so this difference results in an increased margin for the infusing pharmacy if they're on the 4.3% margin. Now, that doesn't take 340B into account. So 340B is a discount program for health centers and hospitals that take care of a disproportionate share of indigent patients. And James Brown Cancer Center is one of those that is in the 340B program. So if you're in the 340B, the margin on chemotherapy is likely to be higher. So many centers probably have an economic benefit from utilizing obinutuzumab. And I'm not saying they're profiting necessarily, but maybe it helps them stay in the black, or there's certainly some benefit to prescribing obinutuzumab versus rituximab. For a typical cycle, it's around $400. So this has made obinutuzumab more in demand. And this has actually driven up the demand for chlorambucil. So as I said, chlorambucil was dirt cheap. And the wholesale price in 2010 was $2,500. Not extremely cheap, but for a cancer drug, reasonable. In the meantime, as the CLL-11 trial was going on and results were trickling in, the manufacturer was purchased by GlaxoSmithKline, and they began remarketing it as Lucran, the trade name. And the wholesale price in 2013, at the time the trial was starting to report its initial results, was $6,700, more than doubled. And that's for a 100-kilogram patient. So why might you be grumpy? This is Grumpy Cat about the increase in chlorambucil's price. So now a tablet of chlorambucil costs $11. And for a typical Medicare patient, the monthly copay for this drug is $700. That is unaffordable for many seniors. And I've had patients come to the VA asking for chlorambucil. Usually they would come to the VA requesting one of the newest monoclonals or targeted therapies, but in this case they would come for a drug that was generic and should cost dollars. The other problem is for pet owners. So feline lymphosarcoma is sort of the equivalent of CLL for cats. It is a is a feline lymphoma, and when treated with chlorambucil and prednisolone, has a roughly 2-year survival. So in cat years, that's probably the equivalent of being like an indolent non-Hodgkin lymphoma. The cost to treat a cat with chlorambucil and prednisolone is now $165 per month. Yes. So it's the price for that has even become unreasonable. And the reason for this price increase is because of obinutuzumab. So obinutuzumab and ofatumumab, in summary, do have activity in older patients with CLL who are untreated. It's unclear whether they are truly better than rituximab when you take into account quality of life and infusion reactions and adverse events. Even though they are humanized, they do suffer from a relatively high rate of infusion reactions, and they are more costly and have effects on our healthcare dollar. So I'll switch to some of the new stars in the treatment of indolent non-Hodgkin lymphoma, and these are agents that act on the phosphatidylinositol 3 kinase pathway. So that's a mouthful, so I'll call it PI3K. So the PI3K pathway is very closely connected to B-cell receptor signaling, which I mentioned at the beginning. And as I said, B-cell receptor signaling is important for clonal selection of B cells and B-cell survival and proliferation. And all of this takes place through the PI3K pathway. And this is a signaling pathway that's found throughout our bodies and governs cell growth and a lot of other cellular functions. And for B cells, the delta isoform of PI3K is important. And drugs that target signaling through this delta isoform potentially can affect the relationship of B cells with their microenvironment and slow or stop their growth. And another molecule that we'll mention that features significantly here is Bruton's tyrosine kinase. And BTK also is a key actor in the PI3K pathway in B cells for regulating B cell growth. So PI3K and BTK will be our major molecules we'll look at in this segment. So this is the B cell receptor, immunoglobulin superfamily, connected to a signaling domain, which through a tyrosine kinase cascade acts through PI3K delta and BTK to stimulate downstream effectors such as the mammalian target of rapamycin, leading to increased cell survival, increased cell proliferation, and chemokine secretion. So that's how things function in the B cells, at least. And so in this clinical space, we have introduced several agents and tested them in studies. And idelalisib acts on PI3K delta and has been studied in most subtypes of I-NHL and is now indicated for treatment of CLL and relapsed follicular lymphoma, both in relapse setting. Ibrutinib, which targets Bruton's tyrosine kinase, or BTK, has indications for relapsed mantle cell and relapsed CLL, as well as CLL with bad risk cytogenetics in the first line, and also now Waldenstrom's. And actually, ibrutinib is the first agent to have an approval for Waldenstrom's. And the agents that act on the downstream effectors in the pathway, or the mTOR pathway, temsirolimus and everolimus, have been studied in indolent NHL. They're not indicated for lymphoma yet, and studies have shown that they don't have excellent tolerability. So we're not going to spend a lot of time on them. But I just thought I'd mention that there are other areas of this pathway that are being studied, but it looks like the best bets right now are with idelalisib and ibrutinib, which act upstream in the pathway. Temsirolimus and everolimus act more downstream on the mammalian target of rapamycin. So we'll look at idela and ibrutinib in terms of their randomized clinical trial data in older patients. So these turn out to be very good drugs for older patients. Toxic discontinuation rates are low. The serious adverse event rates are a little bit lower than what we saw in the CLL trials we discussed earlier in the talk. And when added to rituximab or compared against another CD20 monoclonal antibody, there is a much better response rate. So idelalisib, when compared versus rituximab alone, the idelalisib rituximab arm had a much higher response rate, 81% versus 13%. Similar, ibrutinib versus the new anti-CD20 monoclonal ofatumumab had a 63% versus a 4% response rate. And even 1-year overall survival, you could see a difference. And this is in a disease that has a very indolent course, so that's remarkable. I should mention that with ibrutinib, there is an increased risk of bleeding. So if you have a patient who takes ibrutinib, you have to be very cautious with anticoagulation. So here are some of the survival curves, and these are quite impressive. This is from the randomized trial of idelalisib and rituximab versus placebo and rituximab. As we can see, the progression-free survival separates early and quite a bit, and the overall survival is also significant. You can get a finger or a thumb between those curves. And similarly, the RESONATE trial, which demonstrated ibrutinib's superiority over ofatumumab for relapsed CLL, the curves separate early, and the survival curves also separate relatively early. So the efficacy is undoubtable, and in practice, these drugs are tolerated well. And what I should mention also about them is that they don't care about cytogenetics. So typically, in these diseases, if you have a deletion 17p or loss of your p53 protein, that's a very markedly adverse prognostic indicator. And typically, alkylator-based chemotherapies don't have much benefit for those patients. These drugs don't care. Their mechanism of action is not based upon damaging DNA. It's based upon environmental interactions and signaling pathways. And as a result, what were predictors of poor response to treatment don't have an impact with idelalisib and ibrutinib. I should mention, in combination with chemotherapy, ibrutinib also showed an efficacy benefit, and this was one of the significant results at ASCO this summer in the field of lymphoid malignancy. So, as I mentioned, the mTOR pathway antagonists, everolimus and temsirolimus, have been studied in indolent NHL, but the toxicity is possibly substantial. 67 to 68% of patients may have more severe adverse events, and the risk of toxic discontinuation and even death may be substantial for some of these agents. So to summarize, the ayes have it. Idelalisib and ibrutinib have excellent activity and tolerability in relapsed and refractory CLL, and the efficacy is independent of cytogenetics. And the mTOR antagonists are still being studied, but their efficacy is more limited and their tolerability is quite limited. IMiDs, or immunomodulators. So, as almost all of us have learned in medical school, the first immunomodulator that was introduced was not known to be an immunomodulator at the time. It was introduced as a sedative, and that was thalidomide in the 1960s. And the signaling properties of thalidomide were not known, and as a result, there were disastrous consequences. So thalidomide and its congeners, lenalidomide and pomalidomide, act on a target called cereblon. And in immune cells, cereblon is notable for its ability to modulate immune microenvironments. It inhibits angiogenesis, and it stimulates T cells and NK cells to go on attack against malignant lymphocytes and plasma cells. So part of what these molecules do is that they bind to the ubiquitin ligase complex, of which cereblon is a member. And when cereblon is not bound, you have ubiquitination of certain substrates, and it says unknown substrates because we don't know the full mechanism of action of these agents. The relationship with cereblon has only recently been delineated, but the degradation of substrates by the ubiquitin ligase complex leads to normal signaling and development. Binding of an IMiD agent changes the degradation of substrates within the cell, alters cellular signaling, can cause developmental defects, but also apparently can turn on T cells and natural killer cells to eliminate malignant plasma cells and B lymphocytes. So IMiDs have been studied in indolent non-Hodgkin lymphoma, and in the relapse setting there is modest efficacy, but relatively limited tolerability. Toxic discontinuation rate was 19% for lenalidomide in relapsed INHL with a high dose reduction rate. In the first-line setting, however, it was tolerated better. Now, these are phase 2 studies, and the overall response rate was 90%. Discontinuation rate was relatively low. However, this was a study population of patients with a median age in the 50s, so this data may not be as applicable to older populations, but there appears to be efficacy in the first-line setting. Now, you might say, lenalidomide works very well in multiple myeloma. What about Waldenström's, which is a somewhat similar disease? And the results were a little bit disappointing. The response rate is not bad, but the hematologic toxicity is excessive. And I would say that, for the most part, I would not recommend utilizing IMiDs in indolent non-Hodgkin lymphoma outside of a clinical trial. So to summarize, lenalidomide has moderate efficacy in indolent NHL. Tolerability is limited. It may be best in the first-line setting, but we don't have full studies in this field, and new agents such as pomalidomide may be better tolerated. So speaking of myeloma drugs, we'll continue with proteasome inhibitors. So there's been some migration of multiple myeloma-focused drugs into the indolent non-Hodgkin lymphoma sphere. And the two that are on the market are bortezomib, also called Velcade, and carfilzomib. And they inhibit the proteasome, which is the organelle that helps recycle proteins in the cell. So they're basically your garbage disposals for proteins. And when the proteasome does not work, you have proteotoxic stress. And these unfolded proteins accumulate in the cell, and that has a negative impact, and it upregulates a pathway called the unfolded protein response, and that triggers cell death. In the one randomized controlled trial in indolent non-Hodgkin lymphoma, which was primarily a setting of follicular lymphoma patients, the addition of bortezomib to rituximab added modestly to the efficacy. The response rate increased somewhat, and there was a very modest 2-month improvement in progression-free survival, but there was no improvement in overall survival, and the toxicity was increased. And bortezomib has neurotoxicity. It can cause peripheral neuropathy, and we saw in this study that neuropathy increased compared to the comparator arm. And the general conclusion was that the improvement in efficacy was not justified by the increase in toxicity. So bortezomib has modest efficacy in this setting, and this is more oncology specific, but for administration of bortezomib, if it were to be used in this setting, it's likely, based upon phase 2 studies, that dosing it weekly and subcutaneously is the best way to go. Weekly bortezomib and subcutaneous bortezomib both appear to have less neuropathy and better tolerability. So I'd like to wind up discussing some new classes of agents which don't have large trials supporting them, but in the future we may be utilizing them in combination with other chemotherapies or as combinations of targeted agents themselves. So I'll mention BCL2, which is a anti-apoptotic and pro-inflammatory protein in B cells. We'll talk about the immunotherapies, CAR T cells, or chimeric antigen receptor T cells, which is basically T cells that are reprogrammed to target specific types of cells based upon antigens such as the B cell antigen CD19. We'll talk about programmed death blockade, which are some of the new immunotherapies like nivolumab and pembrolizumab, which have made a lot of press lately in the New England Journal, primarily for lung cancer and melanoma, but there's also some evidence of efficacy in lymphoma too. And so looking at some of the studies, the venetoclax, which is ABT-199, a BCL2 inhibitor, has a good response rate in follicular lymphoma that's refractory. CAR T cells which have had a lot of press because they have had very dramatic responses, are these targeted T cells, but they have to be administered with a conditioning regimen. So you have to give chemo up front to be able to successfully get the CAR T cells in and get them to survive. So I think CAR T cells are a therapy that's not as well tailored to the older population based upon the rigors of their administration and the possible cytokine storm that can actually occur after they're infused. Pidolizumab is a PD-1 antagonist, the same family as nivolumab and pembrolizumab, and a study in follicular lymphoma showed a good response rate and no grade 3 or higher toxicity. So potentially the PD-1 blockade molecules could have good application in older populations if the toxicity data continues to hold up in that fashion. And I'll also mention the antibody drug conjugate polatuzumab. So this is an antibody against the B-cell receptor, CD79B, which is linked to a mitotic poison. And I mention it because we are going to have a trial at the Brown Cancer Center involving that drug and a couple others I've mentioned, and I'll mention that briefly. Also, the SMIPs, which are basically a variation on an antibody, and bifunctional or bispecific antibodies have also been shown to have efficacy and are being studied. So where are we going with this? So I mentioned this at the very beginning in the disclosures. This is the Genentech Roche trial G029833, and it's going to feature the combination of a CD20 antibody, obinutuzumab, which we mentioned early in the talk, the BCL2 inhibitor venetoclax, and the CD79B antibody drug conjugate polatuzumab. So very few people have looked at novel targeted agents in combination, and University of Louisville, James Graham Brown Cancer Center will be one of the sites of this study, and it'll be looking at patients with relapsed and refractory follicular lymphoma and diffuse large B-cell lymphoma. So we will be enrolling patients hopefully in that soon. These targeted agents have applicability in hematopoietic stem cell transplant. They could be combined with mobilization chemotherapy regimens for autologous harvest because they tend not to have myelotoxicity. They don't poison the stem cells, and they don't cause cytopenias. Excuse me, wrong button. They might be useful in addition to conditioning chemotherapy. There might be synergy with agents, and particularly in post-transplant maintenance, agents like idelalisib and ibrutinib, which are well tolerated, could be given for years as post-transplant maintenance to the patient. And the other thing about idelalisib and ibrutinib is that their activity on the PI3K pathway makes them promising agents for treatment of graft versus host disease. So to conclude, there are several new agents or new classes of agents that are being utilized in treatment of non-Hodgkin lymphoma, especially indolent non-Hodgkin lymphomas. These are novel anti-CD20 antibodies, the PI3K inhibitors, and BTK inhibitors, idelalisib and ibrutinib, which are well tolerated and don't care about cytogenetic adverse risk profiles, and other classes of agents, while they have efficacy, may have less tolerability. Older patients have more comorbidities, and their performance status tends to be less, and they are at higher risk for toxicity. So in choosing regimens, thinking about these new drugs, I think the focus should be safety and tolerability. That is as equally important as efficacy. I'd like to thank my co-author on our ASCO educational book article, Ajay Gopal, as well as my colleagues in the Division of Bone Marrow Transplantation, and my colleagues at Seattle VA and James Graham Brown Cancer Center, who have been inspirations to this project and have also helped me with refining it. So thank you. So the question was, you have a patient with CLL who was treated with an oral agent for a while and doing well, and was switched to a tyrosine kinase inhibitor. Well, not knowing the specifics of your patient's case, it's possible that the drug they've been switched to is idelalisib or ibrutinib, which are the first kinase inhibitors we have in that field. But I would say that in general, hopefully with these drugs evolving, there are multiple lines of therapy your patient can receive which have fairly good tolerability. So ibrutinib is one, and if that doesn't work after a while, they could go to idelalisib and possibly rituximab with chlorambucil in the future. There are a variety of low-intensity regimens that could be sequenced. So there were two parts to that question. One was about monitoring with cell-free assays and the use of these agents, and the other was about CAR T cells. So I'll do my best to address them. I can't say that I'm highly knowledgeable about either field. I think we're seeing more cell-free assays being utilized in this field. For combination with these particular agents, I'm not aware of a lot of clinical data that exists. I think the companies that are performing the trials are trying to collect this data to find out. I would say that these sorts of disease states are indolent, and the need to detect minimal residual disease to predict long-term outcomes is less pressing. In AML or in ALL, it's very important to find minimal residual disease because you have to get on it early with transplant or other aggressive therapy. Otherwise, the disease will take off and take the patient's life. In these diseases, the presence of minimal residual disease is probably a given. No one is going to clear CLL or FL for the most part. And so I would assume that everyone has minimal residual disease. So I don't know what the clinical significance of a little bit of disease that's detectable but doesn't have a symptom impact or a cytopenia for the patient is. I would probably monitor that patient. As for the CAR T cells, I think we're learning a lot more about them, and they are going to become an important part of therapy in bridging patients to transplant and taking care of refractory disease. And we're actually trying to open up studies with CAR T cells against T cell malignancies here at the Brown Cancer Center. In terms of using them for older patients, I'm not sure how that's going to work out. Some of the challenges of CAR T cells involve physiologic stresses that are perhaps better tolerated by younger patients. So radioimmunotherapy, I should mention that the first anti-CD20 antibody that was approved, and it's on my slide of the history near the beginning of the talk, was ibritumumab, or Zevalin, and that was CD20 linked to an yttrium-90 epitope. And in follicular lymphoma, radio-labeled CD20 antibodies, Zevalin, have shown some promise as consolidation or relapse treatment. So It's actually discussed in the article, but for the purpose of the talk, to get everything within the time frame, I didn't focus on that. But there's some data with Zevalin suggesting that a single course has good efficacy in the relapse setting or the consolidation setting. And actually, these agents may be cost effective because you can, while it's more expensive for the one administration, there's just one administration. That's all you have to do. And you could have possible years of efficacy. So that's a good point. Thank you. Okay, so the question related to health economics and acceptable values of human life in older adults. And I think I might rephrase that in terms of what do we consider to be the acceptable limit in terms of what we pay for a quality-adjusted life here. And that's because that's the rubric that everyone's been using. So just to define it, the quality-adjusted life here is 1 year of survival with minimal side effects, feeling well. And so if you help your patient live a year longer, but they have a certain degree of side effects, you might say they had 3/4 of a quality-adjusted life here, for example. So there is no well-defined upper threshold, and we talk about MIC creep with antibiotics, where the antibiotics are becoming marginally less effective. And we're seeing creep in what our accepted cutoff is for what we'll pay for a quality-adjusted life here. The rubric when I was starting my training was dialysis. If it cost more than dialysis, you were pushing it. You know, ICDs were sort of on par with what dialysis cost, and that was thought to be an expensive intervention, but acceptable based on the benefit. And then we had some of these monoclonal antibodies come out. For example, bevacizumab in colon cancer may cost as much as $200,000 for a quality-adjusted life year. And for example, in Europe, they don't routinely use bevacizumab for colorectal cancer. We do in the United States. And so we've been using bevacizumab as a standard in colorectal cancer in combination with chemotherapy. It's an expensive antibody. And then, I don't remember which company, but they came out with one that cost twice as much, but only had the same efficacy. And that was called a aflibercept. And Dr. Saltz from Memorial Sloan Kettering came out publicly against the use of this agent. He basically said, at Sloan Kettering, we're going to draw the line with this one. We're just not going to use it. It has the same mechanism of action as bevacizumab. It doesn't seem to have better efficacy, and it costs twice as much. So we're not going to use it. So a variety of leaders in the field have started to say we have to look at the costs. And I agree that there is some controversy, but we can't afford to pay for everything. And that's not controversial, that we're spending a lot of money, that some of the inflation in our healthcare system is due to drugs. And we have to take a hard look at the benefit to patients. I don't think you can simply say, if it benefits my patient, it's worth doing. I think you have to look at, you know, what if you deplete your patient's finances to pay for this drug? You know, I had a patient who had a copay for 2 months of Revlimid. The copay was $3,000. And I had no idea when I prescribed it that the out-of-pocket cost was going to be that substantial. And I actually have some qualms about it now. So I agree with you. We have to draw a limit somewhere. And I don't know where that's going to be, because what seems to be acceptable is a moving target.